This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
It's our job to help people be as safe and as independent as possible, taking care of themselves, or make caregiving as easy as possible for somebody who needs care. And so when you put that in a hospice context, it's not necessarily about rehabilitation, but instead about how we're going to figure out how to do everyday life skills with the abilities that we have right now.
This is the Heart of Hospice Podcast with Helen Bauer. Today's guests are the hosts of the CareLab podcast, here to talk about how occupational therapists can support people on hospice care. Whether you're a family caregiver or an end-of-life professional, the Heart of Hospice podcast is here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
The sponsor for this week's episode is Barbara Karnes Books, featuring the work of award-winning hospice RN educator Barbara Karnes. BK Books is proud to offer the End-of-Life Guideline series, a compilation of 5 essential education booklets designed to support those caring for terminally ill loved ones. Visit bkbooks.com today to order the End-of-Life Guideline series to support your journey of compassionate caregiving. This episode is sponsored by Odonata Care, creators of the Hospice Care Plan. Hospice agencies and end-of-life doulas are now using the Hospice Care Plan booklet to support their patients and caregivers. It's become a trusted resource in the end-of-life community, helping to educate and equip caregivers. Visit thehospicecareplan.com today to purchase the Hospice Care Plan booklet.
My guests today are a couple of occupational therapists, or OTs. Emilia Bourland has been an OT for 14 years. Her clinical experience ranges from acute care all the way out to community-based care and more. She's the CEO and founder of Higher Standards Caregiver Training and creator of the DEF tool, which was developed specifically for the use of caregivers providing daily care for people with dementia. She and her co-host, Dr. Brandy Archie, are the host of the new CareLab podcast. Dr. Brandy Archie holds a doctorate in occupational therapy and is a certified living-in-place professional. She's also the founder of Ask Sammy, which is a curated digital marketplace to make aging in place possible for anyone. We had a great conversation today about occupational therapies and how can they be included in hospice care. Emilia explains how an OT is often underutilized in hospice due to the misunderstandings about what the work of an occupational therapist actually includes. We talked about how understanding the priorities of the patient and the caregiver helps the OT to provide good care and improve the patient's quality of life. This is a great discussion about integrating OTs into the care of hospice patients. I hope you enjoy this conversation with my guests, Emilia Bourland and Dr. Brandy Archie.
I am so glad to have 2 occupational therapists with me. Welcome, Emilia Bourland and Dr. Brandy Archie. I'm so glad to have you guys on the show. Welcome.
Thank you for having us.
Yes, thank you so much for having us. We're excited to be here.
So this is a milestone event. I have never had an occupational therapist on the show.
Really?
No.
And today you get 2.
Well, and this is perfect because obviously the hospice world includes occupational therapists, but we don't know a whole lot about using them. So that's what we're going to be talking about today. But to get to know you a little bit, we are going to start with some icebreaker questions from the Death Deck. Have you guys ever played the Death Deck?
I have not played this one.
No, but okay.
Oh, it's one of my favorite things. One of my favorite things. Okay, so it's a huge deck of cards. Some of the questions are reflective. Some of them are a little bit irreverent, a little bit way out there. And it's just all designed to start conversations around end of life and get you thinking about what your advanced care plan might be, how you feel about death and dying, even the afterlife. Mostly it's just a game to have fun and really just have a conversation about something that scares the daylights out of all of us, but we can poke fun at it a little bit. So we're going to start with this. So Brandy, I'm going to pick on you first, okay?
Okay, I'm ready.
Okay. At the moment of death, a secret tattoo appears on your body that symbolizes something you stood for or believed in. What is it and where is it? This is one of my favorite Death Deck questions.
That is a great question. And the answer is, it will be the Bible verse, Proverbs 3, 5, and 6, on the inside of my foot. And the reason this is important and why I have an answer to this is because that's a tattoo I actually want to get, but I probably will never get because I don't know, have no initiative or motivation to actually do it. So I'm not really looking forward to any of the pain, but it is a good idea. But the verse says, it talks about God making lighting the path for your life. And so that encompasses what I believe in and hopefully what I do for the rest of my life.
I love it. But why your foot?
Because it's about walking on a path. It's about walking on a path.
Oh, I got you. So even the location is symbolic. I like that. I like that.
Wow, I'm really glad you got that question.
I'm kind of tempted to make you do it too, but okay, Emilia.
I'll give a good answer. Yeah.
We'll use a different one for you.
Okay.
Emilia, here's yours. Name and explain one personal item that rightfully belongs in your post-mortem shrine. So if Brandy and I were to create a shrine to you after you die, what's something that belongs in there?
Ooh, gosh, that's really, really difficult. Not necessarily because there's a lot of stuff that I love. And I'm sort of like always of the mindset you can't take anything with you, right? But I guess this is more about, something that talks about who I am as a person or something that I enjoyed. I guess the first thing that comes to mind, aside from all of the stuff of my kids that I would like want to have be part of it, is a pair of running shoes.
Ooh. Because
I spend a lot of time, like that's what I do for stress relief. That's what I do for enjoyment. I mean, for me, if I want to have a great day, having the opportunity to go for a nice long run is like the foundation of that great day. And I have some of my best ideas, my like most cathartic moments when I'm running. And I think also well-worn shoes are just a great symbol of, the life that was lived in those shoes too. So I would say like a well-worn pair of running shoes.
Oh, that's great. Okay, Brandy. So now we know when we create the shrine, when Emilia goes on to wherever she's going, we'll make sure that the running shoes are there. Okay.
Old and funky.
I was just about to say maybe a really old pair that's not too funky.
Maybe you haven't worn in a while.
You haven't worn in a while.
Not the fresh ones.
My feet aren't particularly stinky, so they're not. They're not that bad. They're not that bad.
Do you notice a theme here? We got
that is really good to know. I know both of you. I have to say that the tattoo is intriguing, and I love the idea of the Proverbs verse. But I would not do the foot, especially the bottom or the arch of the foot. That sounds really painful to me.
This is the reason why I don't have it, because I know that's the most painful place, but that's the part that like makes the most sense in my mind.
You just need to get somebody to go with you. Emilia, make it happen.
Yeah.
You just need a buddy to hold your hand.
I'll book a flight and I'll hold your hand while you get your tattoo.
If you do that, I will definitely get it.
Or
Okay.
you'll hold her foot. She'll need to hold her foot still.
Oh, yeah.
Right. I'm ticklish too.
Oh my God. Yeah,
Oh
that's
my
not going to
gosh.
go well.
Wow, that's not going to go super well then, probably.
Well, let me know how that works out for the both of you. Okay, so let's get into what we're really supposed to be talking about today. We're talking about occupational therapists and how they're integrated into the care of a patient at end of life. So, Emilia, tell me in 2 words how you got into occupational therapy.
Eavesdropping? Yeah, I know those aren't the words that you're expecting. That's literally though how I did get into occupational therapy. Is I had no idea what it was. And I was at my cousin's graduation actually from college. And I was looking for something else to do. I was working in psychology and research at the time. And I knew that I enjoyed parts of my job, but there were other things that I wanted to do. I knew that I wanted to help other people. I knew that I wanted to do something that was still like evidence and science-based. And I knew that I wanted to be able to be creative. And I knew that I hated being bored. And literally, I overheard my aunt talking about how they always need more occupational therapists. And I was like, well, what's that? I Googled it and it was immediate. I was like, oh my gosh, this is actually what I'm supposed to do with my life. And I never looked back.
Oh, wow. Okay, Brandy, how about you? Tell me in 2 words how you got into occupational therapy.
$signs.
Okay.
And she's laughing because that is actually very funny.
There's some honesty there. It doesn't sound good, but there's some honesty.
2 words. Okay, so now let me explain. So, a lot of similarities between me and Emilia in that because when I was a kid, I always wanted to help people who are sick. And so, of course, the first thing you think when you're a kid is to be a physician.
Right.
But then I realized that you really only see your physician when you are sick. You don't go back until you're sick again, right? For the most part. And I wanted to be a part of that, what I now know as the rehabilitation process. So somebody at some point said, well, you should be a physical therapist because they help people get better and they help them through that part. And so then in my mind, I was going to be a physical therapist. And so this lady came to my high school biology class and gave us this sheet of paper to talk about health careers. So I'm like, oh, I'm going to be a PT. And I found it. And this health career list was in order of salary. And so right above it was occupational therapy. And I was like, well, that sounds like a therapist and they make more money. So tell me about that. And so he told me. And then when I went to start doing a little bit of research, it was like, oh, this is exactly what I'm supposed to be doing because of the creativity and how every treatment is different and all the broad spectrum kinds of practices you can do and have the same degree. And so like ever since then, freshman in high school, which is very strange, mostly for most OTs, I was going to be an OT.
That's awesome. Okay, so full disclosure, that's how I got to be a nurse.
Really?
Not a hospice nurse, right? Because a hospice nurse doesn't make any money than any other nurse in any other silo of healthcare.
Sure.
But when I was trying to figure out what to major in and what to go to college for, I was trying to think, where am I always going to be able to have a job? Which is totally true. There's been a nursing shortage where I work, and now, of course, it's all over the United States. But that was 34 years ago. Yeah. So I'm not getting rich, goodness knows, but I knew I would always have a job. There's always going to be sick people. So, yeah, I see how that could happen. I get that. There's some practicality about that. And if you happen to, by the way, absolutely love what you do and the people that you're working with and what you get to do with them, that's just icing on the cake.
Totally.
Yeah.
Yep.
Yeah. Okay, so we're going to be talking about occupational therapy, and this is a big deal for us because let's lay a little groundwork. Hospice teams include occupational therapists. So for my listeners that don't know this, that is a true statement. They are not one of the core team members. Core consists of physician, nurse, social worker, and chaplain. But there are multiple other team members, and therapists, including occupational, physical, and speech therapists, are part of that team that can provide care. And it's very underutilized. And so here's another true confessions from me, ladies, and I hope we're still friends after I say it. So when I was at the bedside, I never made a referral for an occupational therapist. I probably did not know how to use them correctly, and I never saw it being done, so I never did that. I never made a referral for an OT. So what we're going to do today is take a deep dive into the role of an occupational therapist and how they are integrated into the care of somebody who's in end-of-life care. So important. So, Emilia, we're going to start with you with the first question. Why do people think that occupational therapists can't be involved in the care of a hospice patient?
Well, it really goes back to this kind of like age-old belief, both inside and outside the therapy world. So there are a lot of therapists who also honestly think that therapy can't be involved in hospice. It's not just other disciplines or consumers in general. It goes back to this kind of false belief that unless someone is going to progress in a way that where their function is going to get better, where they're going to get more independent, then therapy can't be involved in that. So again, it's this idea that unless someone is going to improve in their condition and make progress, then therapy is out. Therapy has no place there. And of course, that's not true at all. And also, kind of really limits the perspective and the scope of what we can provide as therapy. But that's the basic kind of belief system that leads to therapy not being involved when it really can be involved, and can make a huge difference in the arena of hospice.
Absolutely. So, Brandy, how do occupational therapists fit in, and how can OT help for people who are in a hospice care and their caregivers as well?
Yeah. So I think it's helpful to understand what the definition of occupational therapy is. And all of us spend our whole career working on defining that in ways that make sense. And so everybody's going to have a little bit different answer. But the way I talk about it is it's our job to help people be as safe and as independent as possible, taking care of themselves, or make caregiving as easy as possible for somebody who needs care. And so when you put that in a hospice context, it's not necessarily about rehabilitation, but instead about how we're going to figure out how to do everyday life skills with the abilities that we have right now. So like no matter your level of ability, we still need to be able to do some basics, which we call activities of daily living. And that's like feeding yourself and using the bathroom. And even if you cannot do those things, they still need to be done. And so what OTs are really awesome at is coming up with creative, unique, and particular to you and your family ways to do those things. So whether that's teaching somebody how to adjust the hospital bed and bring a table over and set up a meal so that somebody can feed themselves, or if it's working on transfers and how we're going to get that person from the bed to the bedside commode as easily as possible, because they're going to need to do that. There's not always going to be a nurse or an aide there at all times, even though they are on hospice. Those are the things that we help problem solve together with families in order to make those tasks as easy as possible and as much as we can as enjoyable as possible. I think the other thing I'd add is that we've been independent people probably since we were 2, 3, 4 years old. And so we've spent decades doing things for ourselves. And as some of those abilities go away, you want to maximize the ones you can do. And so sometimes it's about positioning, a different kind of tool that you need to use, and just like knowing how to do a thing. And so that's what we are really good at doing.
I think that's a great, robust description of OT. And I think it's really important for us to remember that with hospice, 50% of our job is taking care of the caregiver. Mm-hmm. So if we're doing something that makes that caregiving job easier, that's part of the care of the patient. And a caregiver's job is immense. It's 24/7. So when the hospice people walk out of the door and go back to the next patient or the office or their own lives and homes, that caregiver's still on duty. So anything we can do to reduce caregiver burden is a huge help. Okay, so let's do a little bit of a case study with sort of an imaginary patient. I've got a patient whose fine motor is shot. They can't hold utensils. Their gripping strength is really diminished. They may have a little bit of confusion, but the caregiver is still allowing them and encouraging them to have as much autonomy as possible. So feeding themselves, brushing their own teeth. Tell me some solutions you would offer for a patient like this who's really having trouble with gripping and fine motor in the hands. Emilia, you want to tackle that one? And Brandy,
Sure.
you chime in whenever.
Sure. Well, I mean, one of the things that we try to do as occupational therapists is really look at the whole person, both in terms of what their physical or cognitive or emotional capacities are, and then also look at how well the environment is functioning for them, and look at the specific tasks that are important for them to do. So the first thing to do would be to take a look at this whole person and really also have a discussion with both that patient and their family or caregiver about what is the most important thing for them to be doing. Like what bothers them about not being able to use their hands, and then come up with specific solutions. So, but some really kind of simple things that often occupational therapists will do, say, for example, if someone is having a fine motor problem or a grip strength problem who needs to feed themselves or who wants to participate in feeding themselves, is we might change the utensil or change the handle on the utensil to make it so that it was easier for them to hold. Perhaps, as Brandy said earlier, sometimes we can adjust the positioning of a person so that what we thought was maybe just a fine motor problem actually has to do with the overall stability of the body. We can adjust position, we can increase stability, and therefore make it easier for that person to use their hands. So those are just a couple of specific examples. Of course, sometimes we might also work on things like doing tasks that will help to increase that fine motor capacity or increase that fine motor coordination. We might work on things that are going to increase their grip strength. But it really ultimately just depends on the goals and the needs of the person. And in a hospice situation, again, if we're anticipating that maybe the most important thing is not to make that person's hands work as best as they can, because, sometimes the most important thing in the world isn't that you can touch each of your fingers to your thumb, right? It's really about focusing in on what's going to be the best use of time for that person to enhance their quality of life as much as possible.
Brandy, you had a thought?
I think that's a very complete answer. And the thing that I wanted to highlight is that quality of life is like the most important thing. And that's the thing that we're thinking of, I think, as OTs all the time, but even more so when we're in a hospice situation. And so I think eating is one of the things, the one of the first things we learn to do and one of the last things we want to give up. And so that's usually always a part of a hospice kind of treatment. But you might, like Emilia was saying, it might not be that important to get to the bedside commode to use the bathroom. And it just might be easier for everybody and not a big worry to change a brief. And so we work on just rolling in the bed. The caregiver knows how to do it well and that we've got it set up in a way that works. But it is really important to sit in the wheelchair and get outside. It could be any number of things. That's why I think both Emilia and I love occupational therapy, because no matter if two different patients have the same diagnosis, the treatments are wholly different, because everybody has different goals in their life. And so whatever it is that's going to be most meaningful and provide the best quality of life, those are the things we're going to try to problem solve.
Yeah, I see what you're saying. It's very individualized. It's kind of like how we say, pain is what the patient says it is. Quality of life is what the patient says it is. Yeah, and so you have to look at caregiver ability and caregiver quality of life and caregiver burden in a situation like that. So, for instance, Brandy, you brought up the case of the incontinence, whether a patient can get up to a bedside commode, whether the caregiver, because it has a lot to do with caregiver ability too, So that may be a huge dignity issue if the caregiver is the daughter and the patient is a father.
Mm-hmm.
And so they may, every effort, every bit of their energy might want to go towards maintaining that ability to get up to the bedside commode instead of having to change him in the bed.
Yep.
Right? Because it's a huge dignity issue, modesty issue.
Mm-hmm.
But for other people, eating and being autonomous, being independent in that particular task may be a huge thing when it comes to independent identity and thriving. If mom or dad or spouse is able to feed themselves, eating is at end of life is a huge thing for a lot of people, for the caregivers. That's that particular change strikes very much at the heart of hope and longevity. And so it's a really hard thing for us to process. So individually looking at what's important to each patient and each caregiver, it really has a lot to do with the quality of life and personalization of the plan of care.
I think that something that I would add to that too is a lot of times in my experience working with clients who are on hospice and their family members, sometimes there can be discrepancies between those goals, right? Sometimes the client or the patient is ready to move on to a different stage that perhaps the family isn't quite ready for. And so a really important role that I think the whole team plays, but occupational therapy is certainly an important part of that to help people navigate, is how do we navigate and assist people have these conversations with each other about what the goal of care is and what is really going to help facility quality of life. And that's a conversation that I've been, I think, really fortunate to help facilitate as an occupational therapy, in conjunction with the occupational therapy plan of care with folks who are on hospice and their families, is to say, like, okay, what I'm hearing over here is you really want, mom or dad or grandma and grandpa to keep exercising every day or to keep feeding themselves or whatever it is.
Right.
What I'm hearing from you over here is maybe that's not as important to you anymore because it takes so much of your energy that you feel like you don't have time to share stories or reminisce afterwards. So let's have a conversation about what is really going to facilitate good care and quality of life for everyone in this situation so that everyone can have as positive experience as possible and we can all be on the same page as we're working towards these goals, whatever they are. And there's no wrong goals here. It's just about, what people need and what they want, but how can we be on the same page? And I think that that's a position that the occupational therapist is uniquely suited to help people have that conversation, because in our plan of care, as we're writing those goals, it's a conversation that has to be had in order for us to be effective.
Absolutely. I think that's such a good point, because a lot of times the abilities and the goals of the caregiver are not the same as what that patient wants to do. Sometimes patients look beyond their own abilities, what they can still do. They're not necessarily self-aware about their limitations, or they're not particularly honest about the limitations of their caregivers. So take Brandy's example of a patient who wants to get up to a bedside commode, but if you have an elderly spouse who's the caregiver who can't assist due to whatever mobility issues or health issues of their own or strength issues, well, then there has to be, not to sound callous about it, but a little bit of a reality check on the part of the patient. And so the occupational therapist is really poised in a great position to help each party be heard and seen, and to create some realistic expectations around the whole, whatever the issue happens to be.
And I would add to that these are not just like three people in a room talking. This is two people that have a serious relationship, a spouse or a parent, a child. Like, you have history and baggage. And so when you insert a professional, especially one who is used to having these kind of conversations that Emilia was talking about, it can really diffuse a situation and allow for like some middle ground to be understood, and also to be like, you hear, you know, if the two are not agreeing, or they have two different views about one thing, you know, then coming at each other with it sometimes can be explosive or depressing, or, you know, all these other emotions that we might consider to be negative. And then when that gets directed to a clinician who has experience and who has been respected, essentially, then you're not taken as, oh, my daughter thinks I can't do this, so you feel all these other feelings. It's just like, oh, this is a thing, and we're going to work through this. And it just takes a lot of the emotion down a notch. I'm not going to say it takes it out of it, but it takes it down a notch. I like to say, you know, even in a context like, hey, blame it on me. You know, if we've had a conversation about something and they're supposed to be following through with a thing and I'm not there, just say, you know, Mom, Brandy said that you need to do da-da-da-da. Yeah, she did. Okay, I'm going to do that. You know, as opposed to, Mom, I need you to do da-da-da-da-da. You know, it just gets heard differently. And so even if it's just for that diffusion piece of it, I think we can be really helpful.
Yeah, I've done that myself. Yeah, just tell them, you know, the hospice nurse recommended, and that way the person who's the caregiver doesn't get that flack off the patient.
Make the clinician the bad guy. That's what
totally.
I tell them. I don't live there.
I tell my patients all the time, like, make me the bad guy.
Yeah,
that's fine.
Right.
You know, and I'm happy to be that bad guy if that's who I need to be. And you know, hopefully, because the goal is for you all to have a better experience. I'm going to go home at the end of the day. It doesn't matter.
Right.
Like, lay it all on me. I don't care.
And we're going to say things that people don't want to hear, right? In end of life care, we say things that are really hard for people to hear all the time. Nobody wants to be told 95% of the stuff that we have to lay on them. So you guys actually function a little bit as mediators at times like that, don't you?
Yeah, absolutely.
Yeah.
It can be a difficult place to be, but I think, you know, the way you were describing it, Brandy, some of these situations are emotionally charged. People are tired, they're grieving, they're financially strapped, they're trying to work, maybe they're trying to raise children and be a caregiver for someone at the same time. You know, that's a lot on people, and it doesn't make for great relational conversations, you know? Plus any additional baggage that they've already had, that they're already carrying before they even get to this particular time where they need occupational therapy and end-of-life care.
Absolutely.
Yeah. We're going to break for just a minute. This isn't the end of the episode. There's more to come, so stay connected.
Want to learn more about caring for someone at end of life? Discover the End of Life Guideline series by Barbara Karnes. Here's Barbara Karnes to tell you more.
There is a normal, natural way of dying. My materials are written to guide and support anyone who is addressing end-of-life situations. The goal is to help people have a positive experience so families will have a sacred memory to carry with them.
The End of Life Guideline series prepares readers for the natural, normal process of dying and grief. It's a compilation of 5 of our most popular books, including A Time to Live, Living with a Life-Threatening Illness, The 11th Hour, A Caring Guideline for the Hours to Minutes Before Death, Pain and End of Life, What You Need to Know About End-of-Life Comfort and Pain Management, My Friend I Care, The Grief Experience, and the most widely used hospice book, Gone From My Sight. To order the End of Life Guideline series, visit bkbooks.com. This series is available in digital format, and volume discounts are also available. Just visit bkbooks.com. If you're a hospice caregiver looking for resources to enhance your care, look no further than the Hospice Care Plan, A Path to Comfort. Available in both English or Spanish, this invaluable resource is designed to support caregivers in providing the best possible care for their loved ones. The Hospice Care Plan for Modonata Care now has integrated QR codes in each section of the booklet. Readers simply scan the code with a smartphone, and a free playlist of videos provides practical tips for caregiving and symptom management. It's like having a personalized guide at your fingertips. Caregivers will find 150 videos offering expert advice and practical guidance to navigate every aspect of caregiving. Hospice agencies and end-of-life doulas are now using the Hospice Care Plan booklet to support their patients and caregivers. It's become a trusted resource in the end-of-life community, helping to educate and equip caregivers. Visit thehospicecareplan.com today to purchase the Hospice Care Plan booklet. Empower yourself and the ones you care for with the Hospice Care Plan, a path to comfort. That's thehospicecareplan.com.
Let's talk about why hospice people don't refer. Why this hospice nurse, why hospice people don't necessarily refer for occupational therapy. Why do you guys think that? Because I think it's terribly underused. We know that it's very underutilized. Why aren't hospice nurses and hospice teams asking for referrals for occupational therapy?
Well, I think that a big part of it is just because in general, I think we're one of the more poorly understood members of the interdisciplinary team in terms of our scope of practice and services. And I'll be upfront in saying, I think partly that's the fault of occupational therapists. I don't always think that we're good advocates for ourselves and for explaining the value that we can bring to the team. And I do think we're getting better at that. And, there are people like Brandy and myself out there who are really trying to be better advocates for the profession. So partly it's self-inflicted. Partly, I think it's also confusing because our scope of care is really large.
Mm-hmm.
And basically, if you put any situation in front of us, we're going to say, yeah, I can help with that. And I think it's a little hard to wrap our heads around the fact that most of the time that's actually going to be true, that you can use an occupational therapist in basically any situation. And if you can't, the OT is going to tell you, no, I'm not appropriate for this. But I think it's a lot easier to refer people when you have a better understanding of that other profession. And I think, occupational therapy is just not super well understood. That's at least one aspect of it. Brandy, what do you think?
I think that's the foundational reason, actually, because, the other things I was thinking were, in a hospice situation, improvement is not necessarily what our goal is, right? And if you associate occupational therapy and therapy in general, because we shouldn't leave out physical therapists either, and speech therapists, if you associate us only with working towards improvement, then of course you wouldn't refer, because you're not seeing all the other reasons why it would be beneficial to have a therapist as part of the team.
No, it doesn't seem like a good fit. It's out of alignment with what we do. But when in fact, if it's all about making people comfortable and enhancing quality of life, right? Occupational therapy fits right in front of there. So for my listeners who are caregivers or patients themselves, people who are consumers of hospice care, how can they advocate for themselves to receive or have an occupational therapist as part of the care that they're getting from their team? Brandy, you want to kick that one?
Well, now that you're listening and you know all the ways that we can be useful, you could just ask, because it's part of the deal, and they can just make a referral, so it's not like you're asking for something out of the blue. It's just that they might not have thought that this was necessary. If you feel like you don't remember the word occupational therapy, or just want to say like, hey, I'm struggling with figuring out how I'm going to do these transfers, or how we're going to help with getting dressed or getting prepared to go to do a thing. Or they really want to be able to do XYZ in the house, and I haven't figured out how to deal with that, then you can say those things, and hopefully that will trigger the person to be like, oh, maybe we should have therapy come and help. But I think the best way is to just literally ask for it.
Yeah. To be educated about what your options are. I think that's very important. So we have to acknowledge the elephant in the room, right? Which is hospice agencies receive a flat fee per day for a patient at home that they see. So you could send every discipline on the core team and all the other disciplines out, and you're going to have to pay each one of those people, but the hospice agency is still getting paid the same amount. So we know that, I won't say that they try to do the least that they can, but they do want to be smart about the money, right? And I'm not saying that's not why they use OT, but you have to wonder if that factors into it sometimes.
Yeah, I think that's definitely true. And I would say that the research shows that using an occupational therapist is a money-saving endeavor.
Oh,
And so
tell me about
yes.
this.
So within healthcare, and there's been studies to demonstrate this, if you use an occupational therapist, the expenditure for healthcare costs goes down, even though you paid for an occupational therapist, because a ton of what we're doing is preventative in nature and allows for less wounds and more mobility and less calls from the family about needing some emergency help because they now know how to handle XYZ situation, because there's so much education as part of being an occupational therapist. And so this crosses multiple settings, and it's because of the underlying things of education and prevention and tailored service towards what their goals are.
So you're making that caregiver and that patient feel more comfortable, more confident, more adept in what they're doing. And so those calls, again, we don't get paid extra for the calls, but we are paying our employees. And so we're looking at the hours that they invest, which means you've got families that will more likely stay at home, which is typically where hospice patients want to be. They don't want to go back to a hospital. So you're making them feel confident in the care that they're providing. I don't talk so much about, actually, I never talk about billing here on the podcast and regulatory stuff, but I think it's important for people to know that if they were to ask for a therapy, like physical therapy, occupational therapy, or speech therapy, the patient and family don't pay extra for that. But it's also good for them to remember that the agency does not get paid extra for that either. It's just good to know. But so if a patient and family should ask for that, they don't have to worry about any kind of financial problem for them. There's no bill for them. Yeah.
And in fact, it's a covered service under Medicare. And in fact, it's a required service under Medicare hospice services. If it's necessary and reasonable, it's a required service for the agency to provide.
And that's a really great point to make. So if you are a hospice caregiver for someone you love, or you're a hospice patient, and you ask your agency saying, I have a legitimate need for an occupational therapist, can you provide that? And they tell you that they do not provide that, you need to talk to your agency, because by regulation, they are required to have that accessible to you if it is a legitimate need and there's a reason to have it. So if they tell you they don't, there's something wrong with your agency.
Mm-hmm. I think that there's only an exception to that in extremely rural areas, basically, where there are literally no therapists around. Right. And even now that, with COVID, access to virtual services, which a therapist could still be helpful in hospice under virtual services if that was the only thing that you could get. So even now, it would be harder and harder to like really fit into that loophole, I think.
Right. Thank you for making that point. That is true. There are staffing shortages for every discipline. Every discipline across every healthcare silo, actually. And occupational therapy is not immune from that. So unfortunately, that is one of the things that we do struggle with. I want to ask you, Brandy, we'll start with you. What challenges you most in the work that you do as an occupational therapist?
What's the most challenging thing for me? That's a great question. And it doesn't have anything to do with patients, because there's been literally 0 times where somebody had a problem and we couldn't come up with some kind of solution that I could feel good about offering. Now, did they want to do that thing? Maybe not. They don't always do everything I ask them to do.
That's true.
But there's never been
You're not magic? Why aren't you magic, Brandy?
I'm really close.
You are really close. She's as close as they come, folks.
Listen, she would be the only one in healthcare that's ever been able to do that.
I think the thing that's most challenging are the rules and regulations and payment barriers. Okay. So like, a good example is at my company, we've been able to get some grant funds that we are giving away to other people for equipment. And so this is one of the most fun things in my profession or in my career so far, because we get to do an assessment and say, you need X, Y, and Z. And I can just say, that fits in our grant budget. We will get it to you. Like, that never happens. You know, it's always a negotiation. It's like hey, let's advocate for you to have OT at hospice. You know, now we got to try to stand up to the agency and say, hey, you need to try to find ways to access it because you're supposed to do that. Or here is the things that we think can be useful for you to do. Okay, well, I'm not strong enough to do X, or I am not able to do Y. There's all these different reasons for that. And so there's always a negotiation piece to it. And so that is the hard part. And mostly it has to do with payment, how our healthcare system works.
Yeah.
Or maybe it doesn't work.
Okay. So what keeps you in this work, Brandy? What's your ongoing why?
I have hope that we can make it better, right? Because like pretty much everybody understands that our healthcare system is broken, right? So if we are not in denial, that's the first step of making change, right? We're not in denial. So that feels like there's tangible change that could happen. And secondly, while I feel like it's important to change things from the top down, we have to have new rules and regulations in the way our system works. Everyday people every day are going to the hospital, getting on hospice, needing services, having issues. And so people need help right now. And so while we're trying to advocate for all of our healthcare in America, people still need to be served now. And burying your head in the sand to me is just like not an option.
Yeah, I agree. Emilia, what keeps you in this work? What's your why?
I mean, I echo a lot of what Brandy said. I think that for me, you know, like I said, when you asked how I got into this is just the thing that I was meant to do. And if I weren't an occupational therapist, I don't know what or who I would be. I find such like wonderful meaning in the work that I do every day, whether I am, you know, treating a patient or I'm doing work at higher standards caregiver training. You know, the goal is to leave this world better than I found it. And sometimes that might be in really small ways by helping a family or a person through one tough situation. And like, that's pretty amazing to be allowed to do that. That's the greatest privilege that you could ask for. But I also hope that I'll be able to contribute to making things better in a bigger way too, where we can have easier access, where people can advocate for themselves better, where people can have better information and be empowered themselves to take better care of themselves. And so it's both those like little and small things, but ultimately I just feel so genuinely honored to do this work at any level that I do it. And I get to go to sleep every night, like knowing that I either actually helped someone or I did my darndest. And I don't know, I can't think of anything better than that.
Yeah, it's wonderful. Okay, you guys are a powerhouse, a dynamic pair of OTs, and you guys have a new podcast. You have a brand new podcast. Yeah, you've got almost 20 episodes going. CareLab, right, is the name of your new show. Brandy, how can listeners find your show and who should listen?
Oh, great question. Well, anybody who's caring for a loved one or somebody, or wants to like maybe think like, oh, I'm going to be the person that when my mom starts to need help, I'm going to be the one who needs to do that. So maybe I should start thinking about that. This is for you. It's also for healthcare professionals and anybody who's caring for somebody else. And we try to make it fun to get started, but also dig, because some of the topics are not always as fun to think about, especially in advance or if you're dealing with it. Right. I don't think I have to explain that to you. And we're having a hospice podcast. But the goal is that people get information when they need it, or just democratization of the information that you need around healthcare. This is a super complex system, unfortunately, and you don't know what you don't know. You don't know what questions to ask. And so listening in on our conversations, I think, is a way to be like, oh, I hadn't thought about that. Or, oh, I can ask for this thing or this service. So that's the goal. And you can listen anywhere you get your podcast from. So wherever you listen to this now, you can find CareLab. And you can also find CareLab on YouTube if you want to watch us.
Awesome. That's amazing. I really appreciate you both. You guys are amazing. I'd love to have you back on the show. I learned a ton. Okay. I have to admit my shame of never referring for an OT. So you guys taught me a lot today. And I'm sure there are tons of hospice people out there listening that have learned from you. Thank you for the work that you're doing and the heart that you put into it. You guys are awesome.
Thank you, Helen. And right back at you. We should also say, like, hey, Helen was just on CareLab. You should check out that episode with Helen on CareLab, because you know it's going to be good because she's the best. We're really, really grateful to be here having these conversations. Thank you for letting us talk about this, because obviously it's near and dear to both of our hearts. But also, like, thank you for being you and you're on episode 500 and something.
Yeah,
that's nuts.
511, 512, somewhere in there.
What? That's crazy. So, wow, congratulations. Round of applause.
Thank you.
Round of applause.
I think it might just make me old, but it is a nice accomplishment, I have to say. And you guys are going to get there too.
Well, thanks for having
so
us.
much.
Be sure to catch the next episode of the Heart of Hospice podcast. You can find more episodes on theheartofhospice.com, and don't forget to follow on your favorite podcast platform. You can connect with the Heart of Hospice podcast on Facebook and Instagram, and send your questions or comments by email to helen@theheartofhospice.com. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.